to all of you.
It's a psychoanalytic response.
Are we going to test
My first thought is, you've got to be you if you're not being authentic. So I couldn't say how I do it, but something happens. But if you have a sense of being interested in somebody and welcoming them, that's going to be communicated.
I think for me, understanding the sort of neuroscience of attachment, being aware from the first millisecond, literally the first millisecond, of the dance of two nervous systems in the room, just the moment you catch eye contact with your new client. I sometimes tell my clients about the power of first impressions, and there was a lovely piece of research that was done on teachers in a school environment, and they had a teacher who went into a class, I think, for 10 minutes, and they had a teacher that went into a class for a week, or a day maybe, and had a teacher who went into a class for a full year, and they asked the class the same questions after 10 minutes, after a week, after a year. You know, is this person going to be a good teacher? What kind of person are they? Do you like them? Could you imagine studying with them? And whatever. And the answers were identical. So within 10 minutes, and actually a hell of a lot less than that, within about sort of 250 milliseconds, there's a relationship. And it's astonishing how quickly it happens. We tune in, we're programmed by evolution to be exquisitely attuned to other human beings and to the facial features, and there's so much going on below the surface of which we are completely unconscious, but which we can tune into. So the welcome is in the being, above all. I mean, there's lots of structured ways of then working on to make people welcome, but there's a sense right in that magical first moment. You know, what is the quality of the relationship that's already happening? And does the client feel welcome? And if they don't, it's going to be hard.
Yeah. I just want to say that to a large extent, where I work, the organisation does that. We have a very welcoming waiting room, which is a sitting room. People can make refreshments, have tea, coffee, biscuit, cake, because a lot of them are people who are homeless, people who are asylum seekers that we're working with. And also the letters that we send or the telephone calls that we make is usually done by an administrator who is welcoming them. By the time I see my client, they would have actually had all of that process already. And it's a matter of me introducing myself, who I am, what we're going to do, and what my title is before we start working together.
I don't work in that kind of setting, but of course for me the first contact has normally been on the telephone, and I think the quality of the voice is often what has first been picked up, and people can tell whether your voice is warm or cold, or whether you feel that they are an annoyance or a nuisance to them, or whether they can feel that they are welcome in your world. And when they come into my space, I indicate the various places that they are welcome to sit, and say, wherever would be most comfortable for you. And once they've sort of settled in, or not, many times people will sit initially on the edge of a chair. They can't allow themselves to sit back in a chair right away. But my first question is often, how can I help you? So that I allow them to define what kind of help is needed, what they are there for, and I try to make myself emotionally available to welcome whatever the trouble is going to be. I do not think about this person as a traumatized person or as a diagnosis, but as a person who is in some kind of trouble, or he or she would not be seeking my help. So I just say, how can I help you, and let them begin in one way or another to tell me. Sometimes they tell me verbally, sometimes they tell me non-verbally, and it goes on from there.
As I'm a great a person who really trusts in the field, then I trust that the meeting has happened before I've really spoken to the person, and that they're drawn to me for a reason. And I do my best to be present, to be open-hearted, and if, as I meet the person, something happens that I don't feel like that, then that's of interest to me, whether I'm working individually or in a group. When I'm with a group, my first word is welcome, and then I talk a little, and I just watch what's happening with the group, watch what's happening to myself, and see what I need to do in order to attune to the people who are with me, and the same is true with the person who comes into the room. But for me, it's mostly about a curiosity about that first meeting. How do I feel in myself? Am I open-hearted? How are they doing with me? And it's an exploration from there on.
I just add, how many of you have a website? Quite a lot of you don't. I think these days, having a website to make people feel welcome is actually really important. And the tone and the quality and sort of the body language of the website, the feeling of the website, can be a very important part of the preparation for good work. By the time people come to see me, they've usually had most of them have had a pretty good look at my website. And I'm very transparent in the way I work. I explain what I'm going to do, and I explain on the website. There's client testimonials on there, not marketing myself particularly heavily, but people have a pretty clear sense of who I am and the kind of welcome they're going to get from the website. So those of you who don't have a website, you might want to think about it. It's very easy to make one these days.
So you have different places to start in your work with trauma. So how do you choose the best place to start?
I'm not sure if I've got questions, but it's about how the narrative begins.
Yes. How does the trauma narrative begin? That's a better way of reframing it. But I think there was implicit in it. There's something about being very explicit about a starting point, and that being something that's agreed in a sense when the client looks at the therapist's website and says, yeah, that's the person I'm going to go to, or whatever that is. It's about where does that work with trauma start, and is that an explicit beginning, or is it something that's implicit and unfolds?
Well, in my case, it's very explicit, because all the people that I see are referred by their GPs or by a hospital psychiatry department. So we know what this is becoming about. So it's very clear, but then I don't necessarily allow that to define the starting. I define the starting about how it is being here and what is your story, rather than starting with the doctor told me that, because I don't think that that's particularly helpful. I think that I have to give someone the space to come in and be a person before they become a case.
I couldn't agree more. Even if I had been told by the referring source that there is a trauma history here, I want the person to define himself or herself for me in their own terms, in whatever way that they want to do. And many of my patients were unable to say for a long time that they were traumatized people. They showed me all the signs of trauma, the things I talked about this morning, about emotional freezing and the disorganization of temporality and whatnot, the things that are classical signs of traumatized experience, but they couldn't say that terrible things had actually happened to them. They would tell me that they had had a reasonably normal life, and they couldn't understand why they were here working with me and having so much trouble in their lives. So the idea that they were traumatized and seriously traumatized was something that over time we arrived at together in many cases, in many, I don't want to say cases because that has a particular sense, in many instances in many of the treatments that I worked with people over the years. On the other hand, it's very important to me that I learn from the patient how to work with this person, that they teach me.
But if you remember, I mentioned briefly phased approaches to trauma work, and I think fundamental in my mind right from the start is what's going to give people a sense of safety. And also what's going to give them a sense of hope, that somehow in how we explain about how we work or how we're approaching them, we have to convey that we're hopeful that something could make a difference. So the initial meeting, I may not be finding out a lot about what's happened to the person, but there's something about, again, establishing our relationship. I will offer to talk a little bit about me and how I work. But I'm also, if I know there's trauma around, I will be trying also from the start to slip in aspects of psychoeducation. It may be just saying, oh, would you be interested if I shared with you something about the brain that might help you understand why you're having these difficulties? Or I've got a model I could show you and I think it might interest you, and if it makes sense, that could be something we can keep coming back to. So then I would introduce something like the window of tolerance. And I think the amazing thing about very simple psychoeducation is it starts to normalise things for people. It's, oh, other people have also experienced that, and this is kind of normal. It's normal to go up there, and it's normal to come there, down there. So that in itself, I think, begins to build a platform for whatever happens later. And also on that idea of safety, thinking about the idea of this is two bodies in a room again, and it's about the right brain to right brain connecting. So it's not necessarily quite what I say or what the person says, but it is from the start, how can we be a neuroregulator for the client?
You've all heard each other speak, and there's a lot of agreement between you. And I'm wondering if you can, what are the key differences, do you think, that you've come up against during the course of the day? What is really different about the way you work?
I guess one thing for me is that I work predominantly with groups, and the other one is that I don't have that much interest in the story. I'm much more interested in the actual events, the traumatic events that have happened. So if we take the client that we talked about, that we have as much of the story as I need there. We have all the most important events, and then I'm just phenomenologically there, feeling into my body, what's happening for me, looking at the client, watching all their non-verbal processes. And if it's a one-to-one, I may just say a very open question.
Do you think that phenomenologically feeling into your body is so very different from the way that Sue and Donna and Lennox would be working?
No, that would be the same, but I would not be so interested in the story. That's really the difference. So, yeah.
There is a certainly a difference. You would have picked up that I use a lot of the fundamentals of psychoanalytic understanding of what's happening in the transference and counter-transference, and my intuition. I'm using my intuition a huge amount. But what is really different about the way I work, certainly, and the way I've learnt to work, is I get stuck in. I have this sort of revolutionary idea that clients paying quite a lot of money, it'd be nice if they paid a little bit more, but anyway, in their world, paying quite a lot of money, that they come in, they want to get better, and they want to get better as quickly as possible. And so I say to my clients very clearly that my job is to get you back out that door feeling a lot better about yourself as quickly as possible. And if it can be done in 3 sessions, fantastic. I've had one chap came in 1 session. He literally had 1 session. He wrote a book about it, literally. A chap called, name will come back, Matt McAllister. He wrote a book called Bittersweet. And he's a journalist, and he came to me saying, I think I've got PTSD. I said, okay, right, tell me your story. I got my checklists out. I use checklists quite a lot, depression scales, anxiety scales, impact of event scale I use a lot. Fairly early on, quite often. PTSD checklist.
So Mark, I'm going to cut across here, so you get stuck right in. I'm wondering how that, say, fits for Lennox and for Donna, getting stuck right in.
Well, I do get stuck right in, but I don't privilege the trauma. I'm interested in the client or the patient, actually, and I'm interested in their story. And I'm very interested in the story because I think the story helps them to redefine themselves and their ability to cope with an aspect of their life, which is the trauma, which I think, yeah, it's interesting, it's useful to get to it, but I'm not going to rush there to get to it. I get to it in their own time. That is the basic difference. I am interested in the story. Probably too much.
And I would say that I am probably closest to Lennox in my way of working, and it's not a mystery because we're both psychoanalytically trained. I would say that I'm interested in the story exactly as much as it's important to the person with whom I'm working. And insofar as aspects of the story are unimportant to that person, most of the time they're also going to be unimportant to me unless I feel that there's something missing that's keeping us stuck somewhere. And then I might, really ask about something. But the story, my story is who I am. And for me, if the person I'm talking with is uninterested in my story, they're uninterested in me. I know that's not what you mean exactly, but I would feel quite abandoned by a therapist who just didn't want to know what my story was. And what gets defined as traumatic in my life, little by little comes out, just as you're saying. And that seems to, for some people, that's front and center right at the beginning. They came to me precisely because they wanted to work on something traumatic. But for a lot of people that I work with, that is, as you say, something that emerges as an aspect of their story as they're trying to get their lives sorted out, if you will.
Can I just follow up? One of the reasons why this notion of getting stuck in really, I have feelings about it, is that I spent the early part of my career as a hospital psychiatric social worker. And I had people in white coats saying to me, Mr. Thomas, there's the traction in the far corner of that ward that I'd like you to see. And the patient was defined as the man in traction, not as a person. And I found that very, very kind of dismissing of common humanity. And I didn't want it to pervade what I'm doing here as a therapist.
Getting stuck in, just in defence, in a sense, is getting stuck in with the individual in the room with their story. I love the Victor Yolong first opening question with what ails and how can I help? So the story is absolutely central, and there's a dance that begins to emerge. And getting stuck in means working out very quickly with the client, what do they want changed? Why are they there? what would it look like when this problem is solved? So we sort of do success criteria really early. Okay, how are we going to set about? Where do we need to get stuck in? Where did the wounding happen? A lot of psychoeducation as well, very early on. In fact, I talk probably quite a lot in the first couple of sessions, and they like it because suddenly they begin to understand often. I don't get extremely massively DID, I don't get psychiatric cases on that, or I get the worried well, so perhaps I'm in a relatively sort of luxurious position.
Thank you. I've got two separate but linked responses, and it's partly coming out of what in our discussions I've been seeing as similarities. So one similarity I see is that in all the different ways we're working, we're trying to find a way to recontextualise the past. So if you think that trauma means that the past is haunting the present, what something is needed to happen to recontextualise it? And I think that for me it's both about, it can be recontextualised in a new form of relationship, but maybe what sensory motor adds is it can be recontextualised through new body experiences. So that's the one thing. The other thing is I think we all find ways to drop down into a deeper process. Because unless that happens, you aren't going to get something that transforms things. So maybe again, a sensory motor therapist will be using rather different ways of dropping down compared to the MDR or compared to my colleagues' ways of working.
Okay, so you 5 therapists are in a world where you are the only 5 therapists. And
My fees have suddenly
so get that reality, so as it were, to play. Now just imagine your best friend has come to you and said, look, there's a really significant trauma in my life that I'd like to take to a therapist. Now, who among the 5 would you refer them to, and why? Lennox and Donovic, you've already identified yourselves as being closely related. You're not able to cross-refer. Yes? I'm so sorry. And you must explain why you're not going to send them to your colleagues here.
That's a very interesting question.
Do you want to start?
Yeah, I'll start. Because I've had really good descriptions of what my colleagues do, I have an idea in my mind that if my best friend had a trauma, it depends on the type of trauma they've had, it depends on when they incurred this trauma, if it was really in the past, in the present, wherever it was, if it's a familial one, if it's individual, that will help me to define who I send it to. And I do think I've got a clear idea about who I send it to, well, apart from Donnie, of course. who the 3 I will refer to, because they've given me very clear descriptions of what they do, and what their therapy is about. So I think it's not about their personalities, although they're all lovely. It's about how they've described their work and what their work stands for, what actually it means. That's what we're defining. So who is it? Tell me the trauma, tell me the client, tell me their age, tell me when it incurred. Was it when they were 5, was it when they were 55, was it about their family life, was it about their individual life, was it about something at work? If you tell me, then I'll tell you who I can refer them to.
So we can pull that question, who would you refer Afran to, the Kurdish?
Right, good. Good. I would either refer Afran to Barbara or to Sue. Because they both have components. One about sensory motor, and one definitely about issues in his family and the progressive loss. He has progressively lost members of his family, significant members of his family. And I do think that constellations would really help him. So there you are, you see, you made me declare my hand.
Yeah.
I would refer the client to Sue, and it's nothing to do with how she works or how any of the rest of them work. It's that I feel a somatic resonance sitting next to Sue. And we haven't talked, well, we did talk about it actually, but that's what it is. I feel a non-verbal deep connection to her. So that's the most important thing for me. So if it was my best friend, that's what I send her.
And you going canoeing next weekend?
There might be a company there.
We haven't finished yet.
We all have to do this?
Oh, yeah, sure.
Okay. I want to say that after what you just said, there are some people that, even in my practice, that I would refer to you for some specific pieces of the EMDR. Because I think you're so expert at it, and one, because you said what you just said about not working with serious DID cases, but with people who have some specifically definable traumas, not traumas that have kind of spread through their whole lives and followed them through their whole lives. And I think that now this particular Kurdish client, I'm not sure would be the one that I would send to you. And because I'm not allowed to refer to Lennox, I would say that I would refer him not to either of you two, but to both of you two. I would say that he needs to do a piece of work with each of you. That there is what I would call the ghosts into ancestors work that I consider very psychoanalytic that he would do with you, Barbara, and a re-inhabiting of his physical being that he would come to do with you. So I would like to see him do a piece of work with each of you.
Again, I think I might be sidestepping the question, and I can very quickly track that to I became extremely good as a child to mediating between parents and not taking sides and being nice to everybody. So it's really interesting kind of noticing what that pulls out. But no, the more serious point is, if you remember, I said the missing experience for people is often choice, and it's so important that people have choice. So how could I talk about my colleagues to the friend to give them a sense of choice? I'm also aware, and the, like Lennox, I think I would be also thinking about what each person offers according to that person and their needs. If I'm listening to my body, and I think this is also a really important part of what we do, there was something about the way Donna talked about the humanity and that connectedness, and that degree of welcoming, which I think my body is drawn to. But that's certainly not saying that the other people on the table aren't also offering that.
You're giving us all prizes at this point.
But I think it's because the way you explained it and embodied that.
So do I get to go canoeing with you too?